This is Tyler. Just doing a quick audio check. Pam, I think I see you logged in. Wondering if you can hear me or if you can be heard.
I can hear you through the phone, Tyler.
Great. And I can hear you. So we'll give folks a few minutes. Are you there with anybody else from Shoshone?
Not right now. I'm going to go see if I have anybody available that wants to set in on it.
Okay.
Okay.
Thanks. Hi, Stephanie.
Hello, how are you?
I'm doing well. How are you?
I'm doing well. I wasn't sure if I couldn't hear or if it was just quiet, so thanks for reaching out.
You bet. Pam was just on a minute ago. She was going to do a quick run through the clinic in Shoshone and see if anyone else was able to join. So we'll give folks a few minutes. We're still a little bit early. So
Perfect.
thanks for coming on today.
Yeah, of course. Thank you.
Yeah.
Tyler, this is Pam. Bobby Hapayan is going to join me. Stephanie has patients today, and she'll be here in just a second. She was grabbing her lunch.
Okay. No worries. We'll give folks a few minutes and see if anyone else. We had Stephanie from All Seasons join us as well. So a few people
Okay.
coming on the line.
Bobby's here now.
Okay. Sounds good. Give folks another couple minutes and then we'll get the conversation started. All right. It is 3 after. And so we've got a couple of people from the Shoshone Clinic, and we've got Stephanie from All Seasons. Just so we have kind of a record of who's on the call, would you mind going around just to do some quick introductions? And Pam, we'll start with you and Bobby over in Shoshone.
I'm Pam Lauder. I'm the clinic manager here at Shoshone Family Medical Center.
I am Bobby. I'm a nurse practitioner here at Shoshone Family Medical Center.
And Stephanie.
Hi, I'm Stephanie. I am the behavioral health consultant at All Seasons Family Care Clinic in Boise.
Thank you. And I see Anthony just barely popped on. Anthony, are you there? Can you hear us? Okay. Might have potentially just try to keep an eye on the chat, or if you're able to chime in later. Okay, so today's webinar, we're going to focus a little bit, just a rapid overview. I know a few of us have been on the previous webinars that have been kind of an overview of the pharmacy stewardship topics. So today we're going to revisit some of that at a high level, just really kind of breeze through it, make sure that if there are any questions that we get those addressed, but primarily diving into a lot more detail on what evidence we have in terms of screening and patient identification in the context of opioid use disorder. So in advance, just apologize if there's some background noise. Just working from an office space, so apologize if there's some background noise that does come through. So diving into the objectives for today, again, kind of this overview of pharmacy stewardship and a little bit more focus on screening. Very quick overview, I think, just to go into a reminder of some of the pharmacy practice types. And this, I've found this helpful, and Bobby, maybe look into you as I know Stephanie and Pam have seen this material before, but please chime in if you have questions or want to dive into a little bit more information on any of these topics as we go through a quick overview. So a little bit of a background on traditional pharmacy practice types, which in the retail setting, when we think of the more typical community pharmacy setting, whether it's that small independent pharmacy, or some of the larger retail pharmacies like your Walgreens or your Rite Aid or Walmart, some of the grocery store chains. This is a very fast-paced environment. And a lot of people assume that the pharmacists in the retail environment have a lot more visibility to the medical record or communication with the docs than they actually do in practice. So, excuse me. A lot of times pharmacists are working off of very limited amount of medical information, oftentimes just what's contained in the prescription or what they've filled for the patient historically. And again, it is a very, very fast-paced, often volume-based environment. So the pressure is really to move as many scripts through as possible, and less on spending time with the patient and making sure that they really understand why they're taking the medications or potentially some of the side effects and things like that. We do get a little bit of time to discuss with the patient kind of in that initial consultation, but usually it's pretty limited. Transitioning in the hospital environment, various hospitals have different models for how they utilize pharmacists. Sometimes it's more on the order entry and order verification side, and other times we find pharmacists in a more decentralized fashion collaborating with physicians and other members of the care team on rounds, or potentially in the capacity of antibiotic stewardship, making sure that we're coordinating the right drugs for the right bugs, that sort of thing in the more acute setting. So a little bit of a spectrum in terms of how involved pharmacy might be on the care team within the inpatient side. More and more evidence is showing the value of really that team-based approach, having pharmacists involved in rounds, and especially in the higher acuity areas like critical, like the ICU, intensive care units, and specialty areas like pediatrics, or in areas like the emergency department, where you have either code situations where there's a lot of medications being used, or we're really trying to figure out from a med reconciliation standpoint what's going on with the patient. Could the medicines actually be contributing to the reason that they're in the hospital? So that's kind of the quick overview from the hospital side. And then from the clinical side, this is an area of pharmacy that has really started to grow, I would say, over the last 15 to 20 years. Initially, if you flash back 50 years ago, the practice of pharmacy was really very limited in its collaboration with other members of the care team, and over time really started to become more and more integral into that multidisciplinary team approach. And the education for pharmacists has evolved over time, and so we've started to see more and more often how pharmacists are involved on the clinical care team in various capacities. So Bobby, I know working there in Shoshone, we've got a pharmacist who's integrated into the clinic, but maybe from your perspective, or in your practices, have you dealt with pharmacists, or have you had any experience working with pharmacists or collaborating with pharmacists from the retail or hospital side in the past?
Yeah, we get calls from the retail pharmacies at times, just asking about prescriptions or clarification. And then I've worked in a hospital setting as an RN, and so there's a lot of collaboration, especially with inpatients on antibiotics, being on the bug squad, and just various.
Nice. Were you there in the hospital setting in Magic Valley?
Yes, I was for years, and now I'm over in Jerome.
Yeah, great. Okay, nice. And so again, I actually did my pharmacy residency with St. Luke's in Magic Valley, and so there's a lot of really good collaboration in that environment. Excuse me, with the pharmacists. They have tried to take more of a decentralized approach and get the pharmacist involved in those clinical care teams. So that's excellent, good example. So I want to do oh, go ahead, sorry.
21st of August.
Okay, wanted to do a quick check-in. Anthony, are you able to hear us, or are you able to be heard?
Yeah, I can hear you guys. Can you hear me?
There you go. Yeah, I've got you now.
Okay.
Great. Would you mind, I know we're into this a little bit, but would you mind giving us a quick introduction?
Okay, my name's Anthony. I'm a clinical pharmacist at Mariman Health in Plummer. It's about half hour south of Coeur d'Alene, tribally owned FQHC.
Awesome. And it's actually a really nice segue into kind of the overview of pharmacy practice types. Can you tell us a little bit more about what you do as a clinical pharmacist there?
Okay, yeah, we have three full-time pharmacists, and we kind of alternate weeks. So we kind of rotate weeks out on the floor versus being in our retail pharmacy. We're not really a retail pharmacy, but we kind of operate that way. when I'm out on the floor, we have 6 providers, and so I'm out there answering questions. I'm scrubbing schedules. I'm looking for particular patients that are of interest, and kind of looking through and trying to find opportunities where I can help the doctors out at any turn. So we get to really use our clinical experience and really kind of help out on the medication side of things.
That's great. And it's actually a really nice transition into kind of this next topic of where we see opportunities for pharmacist involvement. Because as you can imagine, when we talk about the continuum of care, and we talk about the clinic delivery system, the hospital delivery system, and then oftentimes pharmacy is in the mix in various capacities across that entire continuum. But there's all sorts of places where we find that patients are confused about, why they're taking their meds or what their medications are for, how they're going to be able to afford their medications if they're expensive. And so when we look at a process from kind of that methodology of a lean process improvement lens, oftentimes confusion and how I've termed it kind of quote unquote waste in the system often leads to rework. It leads to information falling through the cracks, or in the worst case scenarios, it can actually lead to patient harm, whether that be through an adverse drug reaction, or maybe they've doubled up on a medication that they didn't realize was a duplicate as they were transitioning out of the hospital. There's a lot of things that could potentially happen. And so I kind of grouped this area of discussion into maybe some things that you might see in terms of functional barriers or functional sources of confusion, in terms of when we take a look at a patient and the disease states that they may be struggling with. Are there issues with just their day-to-day abilities that might get in the way of their medications? So oftentimes we see 15, 20 different medications on one patient profile, and even just the coordination of filling all those different medications is a huge undertaking, let alone trying to figure out if you need to take, this pill twice a day, this pill 3 times a day, but this one can't be taken with food, or this one needs to be taken away from the 4th one. So there's a lot of sources of confusion that can be possible there. Anthony, out of curiosity, do you find the opportunity to help people out with like med sets, or what are some of the things that when you mentioned, scrubbing charts and kind of looking for opportunities for pharmacist intervention, what are some of the things that you find?
Well, when I first started, I was this gung-ho guy. I'm like, I want to stay away from just like helping people find like cheaper meds or try to improve. I just wanted to be purely clinical. But as time has gone along, I found that just being out on the floor and answering questions about just those kind of questions about prices, about how to just smooth things over between out on the floor versus in the pharmacy, I found that actually that's been a pretty helpful part of what I do out there. I answer questions about how to send medications over, what would be cheaper, what would be more beneficial. Would this patient be beneficial to be on a med set? Just kind of like taking our protocols that we use in the pharmacy and kind of integrating them into like what out on the floor is. And I found that actually improves that bridge between our pharmacy and the medical side. So along with like looking for people that aren't on statins that are diabetics, or being on 20 meds and trying to clean up charts or duplicates or therapeutic gaps or anything like that. Also just processes that help the communication between the pharmacy and the medical side has been really great for us.
I think that's very, very well said. I think often, I mentioned earlier in terms of this evolution of the pharmacy practice and this increased emphasis on clinical, I think there's a danger to decrease the emphasis, or maybe decrease the importance that we place on coordination of care as it comes to education regarding the medications, some of the financial components, and even some of the behavioral challenges that people might face. Because if we really start to address those fundamental needs of the patient, then to your point, we're able to bridge that gap to the medical side a little bit better, and that actually has a dramatic impact on their overall clinical well-being. So I think really good points there. All right. So a quick overview of integration models, and we're fortunate enough to have kind of two different models on the phone with us today. So to give a quick overview, kind of starting at the top here, from the idea of remote support, where we may not actually have a pharmacist on site or within the clinic. But Bobby, you mentioned coordinating with some of the retail pharmacies or the community pharmacies in the area. Oftentimes when folks are admitted to the hospital, that's a really important point of coordination to try to get med histories. And I don't know if you've had the same experience as I have, but oftentimes you really find your go-to pharmacy resources in the area. You kind of know who's going to be a good partner, you know who's going to be responsive and communicative, who might have even more information on particular patients that they support in their pharmacies. So even if we don't have a formal agreement or a formal integration model, your community pharmacy resources are often an excellent source of coordination and support as we coordinate care for these patients. Another aspect of remote support that is a little bit more integrated is what's really kind of a buzzword in the industry right now of telehealth, telepharmacy, these ideas of virtual visits, being able to coordinate consultation models, even supporting multiple clinics from a central hub. And there's been some success using those models within different health systems like the VA, and even in the context of Shoshone, where we have a telepharmacy model that allows us to have a pharmacy satellite in Shoshone that's supported from the nearby town of Gooding. That's been a huge leap forward for that community that was really without a pharmacy for many years. And so we're seeing the benefits of those technological advances in virtual support. When I referenced referral support from multiple sites, I'll give an example of over here in the Treasure Valley in Boise. We actually have a pharmacist integrated into a clinic, an internal medicine clinic for St. Luke's, and she's established a pretty robust practice there. There's a provider panel of I think about six docs and 2 or 3 PAs or NPs that work in that internal medicine site. And then she also supports referrals from another nearby internal medicine clinic and another family medicine clinic that's literally in the same parking lot. So even though each one of those sites doesn't have a pharmacist, embedded into the clinic, that's 3 clinics that are actually being supported by that pharmacist and know the referral pathways, and they're able to plug into that clinical pharmacy resource it's scarce, and so we need to figure out models that can extend that resource as much as possible. One thing that I always like to touch on in terms of the idea of integration and the difference between a co-location model versus an embedded model. And it's not to say that one is better than another. I think the way that I've learned about this over the years of deploying quite a few of these integration models is that the degree of integration, I think, is the key. So you can have a co-location where you could have the pharmacist employed by a distinct entity, but they are co-located within the clinic. But if the clinic and the pharmacy entity are really committed to an integration, it can very much feel like a fully embedded model, which, Anthony, if I'm unless I'm off base, that would be a description of your situation where your pharmacist and the clinic and the pharmacy, it's all under one entity, correct?
That is correct. We're very fortunate here to have a clinic that, I'm literally 10 feet away from the nearest doc, and we have dental, we have behavioral health, we have pharmacy, medical. We got everything under one roof here, so it's pretty fortunate.
That's awesome. And the one thing that I would call out is where I have seen things struggle is where we have either in an embedded model or in a co-location model where the emphasis really isn't placed on integration. And this can arise from a few different things, whether it be a co-location model that is operating in a different documentation system, and so it feels much more like a separate entity, but you might share a space. Oftentimes that introduces a lot of communication barriers. Or I've seen embedded models where, excuse me, the pharmacist might be in a corner of the clinic or not, quote unquote, out on the floor, as Anthony has described. And oftentimes what you get is an out of sight, out of mind. Or potentially if we have a pharmacist who's only able to be in the clinic 1 or 2 days a week, but on the days that they're there, it hasn't really been socialized to the clinical team. And so they struggle to figure out, how do we really communicate with the pharmacist? And I think that's been an area that, as Shoshone has grown over the years, we've integrated Shelby into the clinic further and further. It's just been an area of consistent communication to make sure that the providers are all aware, because we started out at a half day a week and then moved to a full day a week. But we're still evolving this model to make sure that we're spreading the pharmacist resource as best we can, and trying to figure out how to best support all the providers, even though we have limited time within the clinic.
Tyler, I would even add to that, it's like on a provider basis as well.
Yes.
We definitely have, and it's gotten better over the last couple of years, but there's definitely still 1 or 2 providers that I still struggle to reach out to and be like, hey, I can help you. So that's another interesting thing that I wasn't quite expecting.
Absolutely. I would say that falls into a little bit more of the kind of topic that we're going to get into in another webinar, but a little bit today, just in terms of the cultural side of a clinic. Clinics absolutely have a culture for themselves, and working very closely, coordinating as closely as we need to within a clinic. You get different personalities, different comfort levels with a multidisciplinary approach, and sometimes that takes time. It takes sometimes months or years to really feel like we've got solid lines of communication and support. So I did want to call out, Pam, if you have anything to add on how we've socialized Shelby's services throughout the clinic, or how we continue to evolve that and communicate to make sure that even though she's there only a limited period of time, how do we coordinate that effectively amongst the staff?
Pam stepped out, but for a moment.
Okay.
But just some good communication between providers. So even if a provider isn't here on the day that Shelby's here, they'll still have patients scheduled to be a primary or pharmacy consult with one of the other providers doing the face-to-face, and so that's been kind of nice to have that. And then Shelby's here twice a week now, which is very helpful. So.
Yeah, we're happy about that. We're excited to see that program continue to grow and become more of a consistent presence. So that's awesome. I think having that continuity is huge. Okay, so moving through to what I would, you know, the triple aim, which was that focus for a long time, and it's evolved into the quadruple aim, where we have, you know, better care, better health, lower cost, and improved provider satisfaction as the overall aim of the care that we're providing. Really feeling like, you know, effective pharmacy stewardship or coordination with whatever pharmacy resources you have can really drive value in that context. So, kind of wrapping up on this first section, questions or discussion on pharmacy stewardship, the overview, value proposition within the context of the quadruple aim. And if not, we can dive into more of the opioid stuff. So, all right, moving along. So transitioning topics into opioid use disorder, a very quick overview, kind of background before we dive into screening. Just, I mean, knowing, as we're all aware, that this is a really significant issue in the country, and there's a lot of reasons that this has become such a national and international healthcare concern. And rather than focusing on all the things that drove us down this road, and whether the blame lies with the pharmaceutical companies or the pharmacists or the providers, excuse me, I think it's best that we just recognize that we've all had some hand in what's happened over the last, you know, 15 to 20 years that's led us into this situation, and now how do we best support each other to deal with it. So my intent is not to go over this slide in a whole lot of detail, but diving into more of the definition of opioid use disorder as it's defined in the DSM-5 is really getting into this problematic pattern of opioid use that leads to impairment or distress. And so, as we've really noticed, that the opioid epidemic has ramped up over time. There's been a lot of initiatives that have been moving into place to try to counteract that. Some things are going okay. I mean, the thing that I always like to point out, it's not meant to be doom and gloom, but what I would say is we're not out of the woods yet. We saw this, so this referring to this chart on the right of this slide, we're looking at number of opioid deaths, and this comes from the CDC. And so we were seeing this really consistent trend rise in prescription opioids, but then right around 2012, 2013, we saw, you know, this really start to hit the news as an epidemic, and the declaration from, you know, presidents and all this stuff. We started to see this tapering off of prescription opioid deaths. You know, people were saying, "Oh, we're moving in the right direction." The thing that I would draw your attention to is this darker blue line that correlates with this in terms of heroin. So we've seen this increase in deaths associated with heroin, and then more recently, you know, there's this kind of magenta or dark red line, which I think is the most concerning. But this is the fentanyl and synthetic opioids. Very, very concerning due to potency and lethality if anything goes wrong in the use or abuse of those products. Again, I think we're starting to see a little bit of a wave form develop in terms of, you know, some peaks and troughs, and we see some tapering in heroin and prescription opioids. But the cautionary tale would be the dramatic increase in synthetics. Opening up to those on the phone, in practice, is this something that you're sensing or seeing what has been your experience in terms of um, uh, I guess products might be the right term to use, but agents that we're seeing potentially in the communities, or have you felt a little bit sheltered as Idaho often is?
Speaking like from on my end, from down on a reservation, we've been seeing a lot of heroin come in, and that when we're in North Idaho, so it's kind of, I mean, it's no easy way to get it in. So, but I mean, we've been seeing a lot more heroin users and stuff. So,
Okay.
At our clinic, we've seen a lot of heroin and meth as well.
Okay. So I think this is an area where kind of one of the purposes of today's webinar is really trying to bring folks together and say, okay, we know this is still an issue despite some of the initiatives of, prescribing reductions, naloxone distribution, so we have the agents to counteract overdoses if they do happen. Investment in treatment availability. So we're looking at rehab clinics, or expansion of Suboxone prescribing, and educating providers and getting people comfortable with that medication-assisted treatment. One of the things that I think is a hard lesson to learn, but when the initial information was coming out about opioids, and how far the pendulum had swung and how high the doses were that people were on, there was some well-intentioned but kind of draconian ways that providers and or payers approached prescription reduction, and that's where I mentioned heroin and cutoffs in terms of we know that once you get started on this track, it's not something that you can just um, cut cold turkey. It's a matter of working very closely with the patient, making sure they have an appropriate support system around them. And if we cut off too quickly, that's when we often see the jump to more illicit substances like heroin, or getting their hands on some of these synthetics. And so I guess the cautionary tale here is this is a complex and multifactorial approach. And that's actually what we'll see as we transition more into the screening topic. Because now that we know there's an issue with opioid use disorder, we have a definition of it in the DSM-5, but who do we screen? How do we screen? When do we screen? So in my research for this, came across a lot of things that have been developed, many of them just in the last 5 to 10 years. But one thing I kept coming across consistently is there was no clear gold standard for screening. Pausing here, from the clinical practice, Bobby or Anthony, is that consistent with what you guys hear or see? Is there something out there that I might have missed that is really being held up as the right approach in screening for opioid use disorder?
I think that we've gone through several different ones. I don't necessarily know exactly what our standard is for screening right now. I know that we're in the process of trying to have an MAT program kind of get started up, and really the biggest thing that we haven't had a ton of success with it. So I think we're still in the beginning stages of it, trying to get everything worked out. It's been a lot more interesting and difficult than we'd ever imagined.
Yeah, I appreciate the honesty. Bobby, from your perspective, any comments?
In the emergency department, not a specific screening. I mean, we screen for drugs of as far as at the clinic, kind of an annual screening with wellness, but not a generic, screening that we do every visit. So.
Okay. And Stephanie, how about in your practice? Are you aware of anything?
We have our patients take the SBIRT screening tool,
Okay.
But they only do it once a year. We don't have something like them for every visit that they come in or often.
Okay. So again, kind of consistent with what I found is it's a little bit all across the board. We don't have, I mean, if we were to ask, about screening for depression, I'm guessing that, we're all familiar with the basic depression screeners that have been developed over years and years. Um, and so I think what we've identified here is that we we really have a lot of tools at our disposal, but it's a matter of developing a process that's going to be able to be consistently deployed. One thing that I did find interesting, this was a fairly recent recommendation, that in certain populations, those who are undergoing an evaluation for endocarditis, bacteremia, skin abscesses, you can read the information there on the slide, but we should also be looking at opioid use disorder. Often these infections are associated with needle use or infections from sharing needles, and so um, those are things just to be aware of. Um, I wanted to pull this up on the screen. Give me just a second. Just to kind of show more of what I'm talking about in terms of the available things that are out there. So this is from the NIH and National Institute on Drug Abuse, but evidence-based screening tools. So this was revised just as recent as June 2018, so a few years ago, but start to scroll down through here, and you start to see the long list of things that can potentially be used in terms of tools and assessments and screeners and other validated assessment tools. Then found another article from, it was a really nice article from Missouri Medicine, kind of talking about risk assessment tools again. So we have, gosh, they reviewed, I think, 12 or 14 of these things. And then I found a guideline from the American Society of Interventional Pain Physicians. And this is a really good document. In total, I think it's about 90 or 100 pages long. But I would like to go through when we talk about stratification of risk. So this was really interesting to me because they went through a really robust review of the evidence, a really robust review of the intervention strategies and screening strategies, and really the repeated theme here was this isn't an easy thing. It's not just, oh, here's a screener, just do this thing and that's it. So I think the thing to recognize, and for those on the phone, is that, or looking at my screen, is that coming through in a way that you can still see it, or should I try to blow that up a little bit better?
I
I
can
can see it.
You can see it, okay. So I'll try to draw our attention. It just wasn't worth it to me to try to like copy and paste and move a lot of this stuff into a PowerPoint. So I'll try to limit my scrolling, but draw our attention to a few different pieces here that I found really interesting. So in risk stratification, really important to utilize multiple models incorporating psychological, behavioral factors, talking about pain, and so using all of these different approaches, but eventually trying to get to a classification or a stratification into low risk, medium risk, and high risk. So in that, and this is low risk for abuse potential and from a risk factor for the patients. So looking at a few of the characteristics in terms of low risk, and we start to see how this wouldn't be really easy information to just tease out with a 5-question screener. But if we have a really clear objective sign of reliable symptoms of pain, clinical correlation with diagnostic testing. We're talking, you know, looking at coexisting medical conditions. We get into more of the social determinants. We've got controlled personal or family history, or excuse me, sorry, the personal family history of alcoholism. This is the one I was thinking about. High levels of pain acceptance, active coping strategies. So coping strategies that often involve family support, or more of a high level of cognitive awareness that I'm using a substance that can be addictive. Willingness to participate on multimodal therapy. Is that consistent with, when I was reading through this, I thought, you know, that's a fairly complex stratification for what we would think of in terms of a quote unquote low risk patient. Is that, just kind of throwing it out there for discussion, is that consistent with your guys's gestalt or opinion from a clinical perspective?
I can't really speak for like what our providers consider to be low risk, but I do know, like when I'm reading through that, I see that coping strategies, multimodal therapy, we do have a program here that we try to get everyone in that's on chronic opioids, called the Way Forward. And it's, I think it's, I can't remember if it's once monthly or once weekly. They come in and we have a guy that goes through just different ways to deal with pain other than just using medications. And the whole goal is to try to get them to come down on the morphine milliequivalents and use other modes. So I can't really speak as like what they would consider low risk, but it kind of goes along with that.
Nice, thank you. Bobby or Stephanie, other thoughts?
I think just based on looking at it, I mean, again, I like kind of to follow what he said, I don't want to speak for our providers, but it seems like it does align.
Okay.
I think it looks good. I think definitely, you know, people who have better coping strategies or better support are often the lower risk patients. So I agree with that.
Okay. And as we transition into kind of medium risk and higher risk, you'll start to see some similar terminology. Just, you know, let's see. So as we go through, transition into high risk patients. Widespread pain without objective signs and symptoms, aberrant drug-related behavior, history of misuse, abuse, addiction. So we start to see low levels of coping strategies, unwillingness to participate. And a lot of these, excuse me, come up in the screening tools that I was able to find. And so looking at screening for risk, one of the things that I found, and I think is the subject of another grant that is being undertaken right now, but has anyone ever heard of a DIRE, a DIRE score?
I heard
have not.
it. Oh, sorry, go ahead.
Oh, no, sorry. I was just going to say, no, I haven't. I'm not familiar.
Okay, and Anthony?
I have heard of it, but it literally was through the iRopes, one of the iRopes webinars we did a couple months back, and I distributed it to our CEO and our providers. I don't know what the I should say the utility of it has been.
Utility of it?
Yeah, but yeah.
Okay. So yeah, looking at this again, it directionally seems good, but as it comes down to the utility, really going to depend on the clinic and how these things are deployed. So taking a look at the diagnosis, what's worked, intractability in regards to pain, and then this risk category from a psychological, chemical health, reliability, social support, efficacy score, really trying to dive in and objectify some of those criteria that can be so subjective. And in terms of, you know, how well do you think these patients are able to cope with pain? So just kind of scanning through that at a high level. And then moving through some of these other screening tools, and we're not going to, you know, dive into a critical evaluation of all of these, but you'll start to see some repeated themes. So family history of substance abuse, personal history of substance abuse, psychological history of any kind of abuse, depression. We're looking at comorbid behavioral health conditions. We're looking at potentially how stable their family environment is. This is one that I came across in multiple studies that had been deployed in a few different clinical environments. Fairly brief in terms of the assessment. There's another one, and so that's called the Opioid Risk Tool, or the ORT, the Rapid Opioid Dependence Screen, or RODS, RODS, looking at, you know, prior exposure or prior utilization of any of these drugs, whether or not it's kind of getting into, do you worry about this? Do you find it difficult to stop? Do you find a lot of time and energy spent looking for opioids? And so this is another one. Has anyone seen the ORT or the rapid dependent screen in clinics?
I have not.
Okay.
I have not either.
Right. And there's another one. We get into more extensive screening. And one of the things that that I've noticed in terms of evidence-based literature is a lot of times it starts out very well-intentioned, but it often becomes very, very difficult to deploy in practice. And so here's a 7-page description of the revised screener and opioid assessment for patients with pain. So that went through the first version, and this is the revised version. But a brief questionnaire, but it's pretty extensive. So this gets into, you know, mood swings, the feeling of not being able to handle them. Is there tension in home? You worried about judgments? So we're down into the second page now. Do you worry about running out of pain medication? How often have you abused alcohol? Again, we get into history of sexual abuse and family situation. And then we have a whole another section of this document about how to score it. So a fairly extensive screening tool that, again, from a clinical perspective, while it may be useful, I'm having trouble imagining how all of this would be deployed. Current opioid misuse. Let's take a look at this one. Another one that's like a 5-page document to describe the screener. And this one has, I think, 17 different questions that they rank on a 1 to 0 to 4 scale. Pretty extensive in terms of, you know, in the last 30 days, looking back and getting into some more detailed questions about, you know, how they're trying to tease some of this data out. Throw that one to the side, and then move into prescription drug monitoring. Okay, so that was just an example of, gosh, I don't know, half a dozen different screeners. And I'll, I guess, draw your attention back up to some of the other screeners that we've got. So I think my takeaway in all of this research was we don't have a gold standard. There's a lot of tools out there, but probably the most important thing we can be doing in any given clinic is having a standard or a systematic approach that opens up the conversation, that sets an expectation with the patients. A piece of that is utilizing the prescription drug monitoring program. This has been historically a little bit problematic at first because it was difficult to manage your logins, and they had to get changed so often, and you could only delegate your login to a very, under a very specific set of circumstances. But with more integration into the EHR, the EMR, it's getting more and more just part of routine practice. I know I've talked to Shoshone about their utilization of the PDMP. Anthony, is this something that you guys use pretty regularly up there?
Yeah, we try to. We have a new policy in place that any acute opioid needs to, the doctors actually need to run a PMP on it. It used to be run all through the pharmacy, and then we got so overloaded with it that we asked the providers, because you can get delegates for your CMAs and your CNAs to do it. So we asked that they started to get signed up, and we don't get as many, but they're supposed to be running it regularly out there. And then if we ever have any questions, we'll run a backup one to check it out as well in the pharmacy.
Nice. Did you guys get gateway access so that they can get the PDMP reports right through the EMR?
We are currently having our IT work on it. I don't know what the update is on that. I know that we've had several meetings with them. We have a pretty short-staffed IT department, so it's kind of we try to push on them, and then they have 18 other projects going. So yep. we're trying.
Yeah, no, it's good to know that that's moving. Not everyone's aware of it, that it's out there, and I think initially there was some concern about costs, and I know the state has thrown some funding at it. So it's good to hear that those things are moving. Right. But that can be a valuable tool in the toolbox of just navigating that conversation with the patient, utilizing that report. So really, as we transition into the last couple of topics here, and it's just kind of discussion and looking at collaboration, really opening it up to the comments or thoughts of folks on the call, basically saying, we realize this is an issue, and even in the subcontext of screening for this population, how do we do it? What's the right approach? What are your thoughts? Maybe looking to Bobby first, and then Stephanie, and then Anthony, if I could.
I'm not really sure what the question was specifically. I mean, I like the collaboration with Shelby here at the pharmacy. As far as opioids specifically, I mean, I do a lot with the PDMP before ever talking to the patient about any opioids, checking to see what they've had in the past, or if they're chronic users, or.
Yeah, appreciate the thoughts. I'm not necessarily looking for a right answer to the question, just understanding that we're all kind of facing a difficult situation, but especially as it relates to targeted screening in this population, it can be tough. Stephanie, did anything jump out to you during the webinar, or thoughts in the context of behavioral health and this population?
Yeah, I think at our clinic we are unique in that we have a SUDS program here, and so utilizing maybe or exploring how to incorporate these tools more to possibly develop like a stronger workflow from the patients that we see in primary care or who come in for counseling, and connecting them to SUDS or other additional treatment options. So again, that collaborative piece is so important, and particularly within each individual unique clinic as well.
Awesome. Anthony, kind of closing thoughts, comments?
Right. I would agree with Stephanie. You know, we have a SUDS program here too. And I think, and it's more like, I'll go back to the communication between, even though like you could be under the same roof, it's very easy to have fractured communication, and the ball could get dropped in one or multiple areas. So it's very, very important to make sure that everyone's on the same page. As far as like a collaboration opportunity, like we do have a behavioral health out on the floor, a consultant out on the floor as well. So I think that it's very important to have everyone involved in this, and everyone has to play a role. If you only have one side of it, it's very easy just to lose track of these patients. So.
All right, good thoughts. A lot of I guess, emphasis on that multidisciplinary approach, whether it comes in the form of like a formalized program, coordination with whatever existing services that you have access to. I think in the context of just, you know, specifically screening in this population, I think people underestimate the operational lift of implementing a screener. Or once you implement the screener, what do you do with the results? How do you take a systematic approach to the implementation of something like this? So it doesn't just become one extra page that the patients have to fill out on the way in, or that the MA is filling out on intake, and it doesn't really go anywhere. So really appreciate your guys' thoughts and comments and participation, and sharing some of your experiences. And then we've got another webinar coming up, I think in a week or a week and a half, which will kind of be the closeout. There's two more, I think. One is monitoring and ongoing coordination, and we'll try to focus on kind of those treatment rejection strategies and how we support these patients who are actively engaged. And then the last webinar in the series is kind of more on dealing with some of the cultural stigma, and maybe some strategies about how to open up those conversations and help people get the help that they need. So really appreciate you guys' thoughts and comments today. And please feel free to reach out to me if there's any follow-up. But we'll go ahead and close the webinar, and thanks for calling in.
Thank you
Tyler?
so much.
Yes,
I was wondering if you're going to send those slides out.
I can sure do that if you'd like.
Okay, because there was a couple in there that we'd like to review further, you know, the list of different tools that are available. And then I kind of like that paper that had ranked them as low, medium, and high risk.
Yep.
That article.
If you don't mind, I'll kind of put a packet together and just send it to you. So it'll have multiple attachments, but you know, I've got quite a few PDFs that I was able to find that I can share, and then yeah, I'm happy to share the slides as well.
Okay, awesome.
Tyler, can you include me on that as well?
Yeah, no problem.
Same here.
Yeah. Thank you so much.
You bet. Have a nice afternoon and a good weekend.
Yeah,
Thank you, you as well.
We'll see you.